Hello. Before we start our next panel, I would like to share with you a surprise. We are going to have a raffle of Alexa at 4:30. Everyone who's been online will be part of it. Our next panel, Kortstee, consultant of healthcare, is going to talk about the clinical model in the Netherlands. We also have Paulo Chapchap, CEO of Hospital Sírio-Libanês, who will be the moderator. Luiz Antônio Santini, physician and researcher at Fiocruz, and Martha Oliveira, with design and health and Laços Saúde. In room AstraZeneca, health in the Netherlands and the clinical care model. Cabine não está ouvindo, gente. O som não veio para a cabine.
Qual a gente entrega saúde para a sociedade brasileira. Nesse painel hoje comigo aqui, vocês estão vendo o Michiel Kortstee, que vai nos falar inicialmente durante...
So we have here our guest, Michiel Kortstee, who is going to speak for about 20 minutes for the healthcare system. He is director of Valorange and a very important researcher in healthcare, responsible for great changes of healthcare, of the health system in the Netherlands. We also have in this panel Luiz Antônio Santini. He is a professor, a researcher from the Federal University of Rio and also at Fiocruz. Martha Oliveira, the current chairwoman of ANS, and currently working as an executive at Design in Saúde and Laços Saúde. The panel will be comprised of one first presentation by Michiel, and then we are going to hear comments from Santini and Martha, and then we are going to open for a Q&A session. So, Michiel?
Você que vai fazer o upload dos slides ou você...
You are going to upload the slides or the organization is going to upload the slides? Who's going to upload the slides?
Tá. Você tem como fazer também daí, se você quiser.
So you can do it from there if you want to. So I just would like to ask the organizing committee if they are going to upload the slides or if we have to do that.
Tem alguém que poderia ajudar nisso?
Can someone help us on that?
Podemos seguir ao próximo.
So then we can go to the next slide. Next slide, please.
Faço parte de
I am part of Valorange, together with my colleagues, Andrea van der Been and Giacomazzi. It's a platform that has the purpose to address the innovation, technology in healthcare in Brazilian and Holland companies as a matter of partnership. We had a stakeholder survey conducted for the Dutch government, and we were looking for opportunities of collaboration and partnership between Brazil and the Netherlands in the healthcare and life sciences industry. In this sense, we began to conduct stakeholder qualitative surveys and interviews in Brazil, which represent several healthcare segments in Brazil. Since Holland is a small country, the survey was more around Sao Paulo, since we have the Great Sao Paulo, which has more inhabitants than our entire country. So the first aspect was first to understand the needs of this population in our interviews. So we would like to think, what makes you not to sleep during the night as a leader in your field? What is your major headache, your major challenge, and what do you need as a leader to solve this aspect? So this brainstorming shows the key answers. So we focused a lot on how to organize the healthcare system and how the several stakeholders can work together and how they can address the private and public side of the system, how they are able to organize a system that is higher and more comprehensive than its components itself, how to manage the system, and so on and so forth. These were the key answers in this cloud of the interviewed members. And based on that, we are organizing the agenda for today, and now we will address the Netherlands healthcare system. So that's the agenda for today. Can we go one slide more? One key feature of the Netherlands model are the multidisciplinary partnership approach. So we have the Netherlands, and most of the lands are below the sea level. So we had to gain soil from the ocean. So this is the polder model, so to speak. So we achieved that with the mills and with the technological developments dealing with water issues. But in 1953, we had a major flood during a storm, and 2,000 people died. So based on this flood and all the efforts we organized in partnership against the floods from the sea and direct approach towards that, and we also had planning and building of new infrastructure in order to be able to protect the people from the floods. To that moment, all stakeholders, they joined efforts, the government, the companies, as well as the academia, the technology universities, as well as society. This cooperation model between multidisciplinary approach, public and private partnerships, was known as the polder model. Polder model is still being used in the healthcare industry. With some imagination and creativity, this collaboration between all stakeholders and the polder model can be represented such as a diamond, which is the hardest material that enable us to drill even the hardest surfaces in the world. this collaboration between the stakeholders is key in facing the most complex aspects in our society, above all in healthcare industry. I will explain further this Polder model, how it is working in the healthcare industry, and I will share some aspects about the healthcare system in the Netherlands. The Netherlands is a small country with 70 million inhabitants, so that's a very small country. Brazil is 240 times larger than the Netherlands. We have 7 academic hospitals, 3 universities of endocrinology, and other hospitals. And around the university hospitals, we have companies connected to life sciences and health. In terms of competitiveness, they are highly competitive. We had been ranked in the first level in terms of global competitiveness in Europe. We have more than 1.4 million professionals working in this sector. In rankings, we are placed as one of the largest healthcare systems in Europe. Coming back to the Polder model and how it is addressed in the healthcare system. The healthcare system is a public system which is organized between the public and private partnership, and the system is based on the principles of solidarity, access to the quality, and visibility to all. And these are the key aspects: corrective and curing approach, which accounts for 5% in terms of value; the Long-Term Care Act, which is for elderly population and those disabled, and 25% for that, and another layer that provides social support, which is the Social Support Act at the municipality level. The system also contains a mix of general aspects and policies. And we know that as an assured managed competition, so to speak. Since the system was organized in 2006, the government assigned the HMOs the role of the administration of the healthcare center. The HMOs had to inform what were the institutes that they would work and they would buy services from. This new system was introduced due to several reasons. The first one was to create a single system. In the past, we had a public system in place and a private system in place. And this difference for the system that entered in the public system and those that had the private system was based on the income of the patient. I'm having an issue here, but that's okay. At the top of the healthcare system, we have the citizens or the patients that are the people that choose. First, the patient chooses the healthcare plan. All adults in the Netherlands have the healthcare plan that they hire on a yearly basis. So first they choose the healthcare plan, insurance plan. And if the person needs a healthcare provided, they contact a healthcare service and the healthcare plans and the service render or HMOs, they organize the volume, the amounts, and the quality of the services that are going to be provided. So the idea is that the state level is going to decide both in terms of GHMO and the providers that are going to benefit the citizens to use and choose the best offer. So they need to compete among themselves. And that's a competition-based principle. All plans, all HMOs, they have a risk of having a bankrupt if they do not provide the proper service. The citizens have mandatorily a healthcare insurance plan in place, and they need to go first to a general practitioner in the healthcare system. The GP has a key role because it's the gatekeeper in the system, and they know how to answer the 95%, 97% healthcare that should be provided. So they do not need to refer the citizen to a specialty. And this happens only to 3% of the patients. So they provide the guidance in their choices in terms of healthcare. The interaction between the citizens, the HMOs, and the healthcare provision agencies, they have a key role for the government because the government is going to be in charge of the policy, so they are the regulating agencies, the inspectors that will perform the surveillance of the quality of health for everyone. And the healthcare professional has this transparency tool, which is extremely important. Here you can see a site that shows many of the outcomes to citizens, how the citizens can enter in these sites and can be informed about many of the indexes that address the quality of the HMO service rendered, customer satisfaction level, data on mortality, waiting list time, etc. And the same type of data available between the different healthcare insurance companies. And the system that was introduced in 2006 works very well in this fashion. It has been 10 years since its implementation, and the Netherlands healthcare system moved to a very good position in the European ranking index in the healthcare provided to consumers. That's extremely important because we are ranked in second after Switzerland. And what's extremely important is that the system works very well in terms of the patient's perspective, and this ranking is based in different dimensions between the members and users of the system. At the same time, we have many indications with this type of healthcare system. We can better control costs, quality against the former healthcare system. Next.
There is still the need to rethink our healthcare so that it can become sustainable. There are a number of issues involved: aging population, more chronic diseases, demanding patients, the cost of new technologies, which increases healthcare expenditures. If we don't change this path, if we don't change this increase in healthcare expenditures, which is about 13% of GDP in health, we will inevitably spend nearly 20% of our GDP by 2040, which is twice as much as today. 1 in every 5 euros is going to be spent in health, which is not sustainable. The increase in expenditures result from new technologies, the cost of new technologies, and also due to demographic changes, aging population, and more people with chronic diseases. This is why we have to redirect the curve, maintaining the system much more sustainable. In the previous slide, we saw the increase in health expenditures and the need to rethink innovation and the use of technology in healthcare. We're talking about technological innovation, and we've seen that the cost of new technologies make the system become unfeasible. And this is why we have to resort to low-tech, high-impact or high-touch innovation. Even though innovation has been less frequently addressed, I think it's clear to understand the impact of social innovations on healthcare. For example, prevention. For the past 150 years, we have gained 35 years in life expectancy as a result of prevention actions. During this period, only 5.5 years have resulted, 5.5 years of increased life expectancy resulted from innovative care. Now, speaking about health determinant, 50% of our health is related to quality of the environment where we live and our lifestyle. 30% of our health results from genetics and 20% from the quality of healthcare system and its institutions. We should not only focus on responses to health in the 20% that is related with the healthcare system. There are many possibilities outside the healthcare system to really have an impact on health. And this is why we have to focus on low-tech, high-touch issues. We want low-tech, high-touch innovation in different levels. This is Hospital Beerhoven in the south of the country. And there they realized there was a need to transform the hospital. They were wasting a lot of resources, and they had to reduce the volume of waste by about 12% in 5 years. They had a decreased demand. They need to improve quality and reduce costs at the same time. So what do they do?
Não dá para implementar top-down novas
We cannot implement top-down changes without the involvement of doctors and other healthcare professionals. And this is why they invited everyone.
para repensar
They invited everyone to rethink the organization of care
pergunta que eu
by asking a question which I thought was just so much interesting.
fosse
What if the patient were your father or your mother? How would you organize the hospital?
esta pergunta deixou
And this question
os profissionais
has
pensar
really led professionals to rethink the way they work
aos pacientes e perceber
and the way they provided care to patients. They realized that the quality
para paciente que
of care is much more important to a patient than it would be to a doctor. And this is how we started looking and considering the issues.
o resultado do exercício foi
As a consequence,
que os médicos tomavam muito mais tempo desta para a conversa
physicians spend much more time in the visit with the patient, being next to them, asking questions,
terapia, tratamento,
rather than the impact. So really talking about quality of life and what it meant in their life. And sometimes not treating was the best decision for the case.
também melhoraram muitas ações que aumentaram, fizeram muitas ações que melhorou muito a qualidade.
A number of actions have also improved the quality of hospital services.
Numa vez, os tratamentos deram o resultado desejado.
So treatments end up producing the expected results.
Este hospital foi, com esta abordagem, realmente exemplo.
This hospital served as a role model to other hospitals that started working in the Netherlands with the same model afterwards.
Outro olhar para a organização
Another important look to the organization and to innovation in health
olhos e experiência
is to see things through the eyes of patients, someone who wants to enjoy life, be part of society,
para viver sua vida
and live life fully and healthy.
como time brasileiro holandês. Sou
As a Brazilian and Dutch
o prazer em 2018
team in 2018,
contribuir com algumas jornadas
we worked together and contributed with some patient's journey to the White Book of ANAPI,
e cuidados do
making some proposals about health and the cares for tomorrow.
uma persona
In this journey, we followed someone throughout his or her life, analyzing different perspectives. First of all,
pessoa desculpa, a primeira perspectiva é da pessoa mesma.
the perspective of the person himself or herself. What is important to the person? What does the person do in his or her life? What is required in terms of care?
A saúde ocorre.
And how does health take place in fact?
Prestadores explicam
Secondly, providers explain what they need to provide the best care to empower
sua vida.
people.
Numa terceira perspectiva,
The third perspective
novas tecnologias
is to consider how new technology and innovations can provide to support to health more effective, more convenient care to people.
jornadas foram ilustrados com vários exemplos
These journeys were illustrated with many examples and some experiences from Brazil and from the Netherlands.
e esta pirâmide podemos soltar slide. voltar. Esta pirâmide
This pyramid here,
explica a ordem
we can understand
nos níveis
all the different components
e macro.
from the micro, medium, and macro level to create a coherent healthcare system, something which is really effective.
Os building blocks representam
These are the building blocks,
como na Holanda tentamos de criar
and they represent how we try to create our approaches of health and care in the Netherlands.
no nível político.
At the political level in the Netherlands,
O sector da saúde e ciências de
health
vida e cada
and life sciences report to the Ministry of Health, to the Ministry of Sport,
as políticas em inovação
responsible for defining the policies of innovation in health and the roadmap 2020-2023.
de que envolve representantes do
It comprises representatives of what we call quadruple helix:
empresas, universidades,
citizens, companies, universities, and the government.
uma missão central.
They defined a core mission,
Missão central é adicionar no mínimo
which is to add at least 5 healthy years more in life expectancy for all population by 2040. At the same time, we reduce inequalities among
economicamente mais ricos,
socially and economically poor and rich groups.
para atingir esta missão.
And to reach this mission, to deliver this mission,
Formuladas 4 submissões.
4 submissions were designed.
Queremos
And that's by 2024, we want to reduce in the Netherlands
impacto de estilo da vida,
diseases caused by lifestyle and living environment of people. We want to reduce by 30%.
segundo, em comparação
Secondly, comparing to today, we want to increase care
no próprio
in the right place, at home, increasing by 50%.
fora de hospitais,
It means treating them outside hospitals, treating them at home with informal care, using the network of support of the people, resorting to telemedicine technique, providing then home care.
a terceira missão é,
The third mission is
2030, queremos aumentar
by 2030, we want to increase the proportion of people with one disability, one condition,
crônica
one chronic disease.
que ativamente participa na
Someone who can actively participate in the city, in its location,
que ele ou ela.
resorting to innate talents.
4. Até
Number 4,
30,
by 2030, we want to improve people's quality of life with dementia. So, improve quality of life of people with dementia, better saying. These 4 things are fully coordinated and ordinated from the most general to the most specific. And
outras como as bonequinhas de
they just get one within the other as they were Matryoshka's dolls, working from inside out.
por favor, o próximo.
Next slide.
Esta visualização mostra o nosso
This
caminho
shows our path towards self-management. So from self-managed to core management,
institucional para
having a change from the institutional level healthcare to a home healthcare system.
necessário
And if it's required, with a formal support and technologies and special therapy.
para trabalhar nessas
Next,
4 missões.
to address these 4 mission goals, we would have a program to deliver the 4 missions based on several principles. Some of them is to rethink the care of healthcare, which is the care that needs to include the meaning of health. And so it would be the core in terms of improvement of the health itself. We also would have an involvement of the stakeholders in a double helix approach with a higher level of importance for the citizens itself, because we define the programs in a way that is going to be led by demand from society and mainly by the citizens. In order to be able to address the healthcare topics, we need to work together in partnership with other fields. Therefore, the Ministry of Health Department and the Wellbeing and Sports Department, which is the full name of our Ministry of Health, have several crossover with other departments in order to have incentives and drives the quality of the air and decreases pollution, which has a key impact on health of the people. I believe we need to go faster, so we will have time for the discussion. You can continue, otherwise Marta and Santini and the audience cannot ask you questions. Thank you very much, Paulo. Well, what is extremely important is to address in a broader perspective all the healthcare topics. Next, another example is the donut model, which is used to transform the policies in place. So based on this donut model, we try to create a city that prospers in all aspects which are defined by the development goals. Every policy is assessed based on the model. And at the end, we could truly measure through the KPIs the well-being and the health of people. We do that at the regional level, and this image is an example how this tool is used in handover region. Next. You can skip this one. Next. At the end, I would like to mention this quite interesting example of Buurt's work. Buurt's work was organized in 2016, and then we introduced a new healthcare system. Buurt's work, in fact, was organized with the concerns of the state, with healthcare, and it was occurring in the Netherlands. Many fragmented approaches, and healthcare was more addressed and managed as a factory with supplies and offers such as one size fits all. And so we had a high volume at the state level of services that were supplied with very high level of profit and a lot of lack of satisfaction from both the customer and people that were working in home care, healthcare models. And the founder of Buurt's work began at that moment to introduce a new model in which teams from 12 to 10 nurses meet the requirements in neighborhoods from 5,000 to 10,000 people in this home care healthcare system. And these nurses have a way to address patients in a more holistic approach. So they have a high level of interaction and a holistic approach towards the clients. They provide services. And these teams of nurses, up to 10 and 12 nurses, they do not have managers. They are self-employed, and they do all they can to provide an excellent health care. And this organization applied several concepts that I try to explain in my presentation. And the approach contains several examples of social innovation, and this organization has now 15,000 nurses meeting the needs of healthcare and home care market. So I would like to invite Marta to reflect on this model. It has several perspectives from the Netherlands, and probably she brought this concept to Brazil. So I will conclude with the next slide, and then I'll give the floor to Marta. My final remarks, I believe this replaced and mentions everything I wanted to mention on the path of evolution in health care system. If I is replaced by we, an event will be transformed from illness into wellness. Thank you very much for your presentation, and Marta. In fact, we have more 20 minutes. We have until 3:10. And I would ask Marta and her team to have her remarks in 5 minutes, because we already have some questions, and it would be interesting to meet the needs of the audience and the expectation of our audience. So now, Marta, you have the floor. After that, Santini, and then we will come back to the questions. Well, Paulo, Michiel and Santini, thank you very much. I'm very pleased to be here. I'll try to be very brief because my voice is not okay. I don't know if you understand exactly what I'm talking about, but I'll make my best. I will talk about the Netherlands system is very good for me because I spent some time studying that in my studies, and I was introduced to this model thanks to MAPI, and we had a chance to have a tour there. We visited several hospitals at NAPI, and when I was there, I fell in love with the Buurtzorg model, because think about urbanization. I know we have 3 months here to talk about that, about the private interface, how this is integrated in the perspective of the public healthcare system provided there, the way they do that. There is extremely interesting, the quality competition at stake, and I had a chance to know all those levels, and since I could see this entrance gate, Buurtzorg is that, I fell in love because in fact I was studying the models of elderly patients in Brazil, and I had Buurtzorg way of having this entrance door and having this home care approach, they have some affirmations and they say some statements, which is make it simple. So have a more holistic approach where you are able to manage the patients in a more comprehensive way, integrating technologies and rescuing the care. So I fell in love for that, first for the care system in place, and after that with the management approaches and governance approaches as well, which are quite unique. But why we decided to apply this model here? Because first, I believe we needed this different approach towards the elderly population and how we are growing old, etc. But I also believe that in the middle of this pandemic, we are showing that we have some needs in a more opportunistic way, so to speak. So use this technology now available, the home care need, to rescue the care of those chronic patients that are at home, isolated in social distancing, becoming more fragile. So I believe there are several elements that makes it an excellent opportunity to have this new approach to have the elderly patients treated in our healthcare system. So I will give the floor to Santini, and I believe it's important to have the questions of people and to take this opportunity of Michiel here because we cannot meet him every day. Thank you, Paulo. Santini, you have the floor. Thank you. I also would like to thank for this opportunity of attending this meeting, and I would like to thank for this presentation of Michiel, which was extremely interesting, and the kindness he had of referring some data before the meeting about the Netherlands system so I could be better prepared for this discussion. Very briefly, and not using the time for questions, which I believe are more important, I would like to highlight two aspects which I believe are key. First, differences. Of course, we have huge differences in terms of territory and among the countries, differences and inequality. Inequality in Brazil is something scary and makes it difficult to apply any improvement proposal, organization proposal, because at the end of the day, we need to meet different demands of the populations which are extremely different from one another, and with resources and technologies which are quite differentiated. So first, there is a key difference which is important to highlight. But what can we learn from this system? I believe that the most important aspect, a key aspect is the collaborative model. The idea that the healthcare system is part of a more comprehensive social system, where it's essential to have the cooperation between the different players and stakeholders internally and outside the system. This aspect, I believe, is core in this process, and we can learn that from them. And the second aspect is the planning in the long term, establishing targets and goals to be achieved, even considering all the local differences and regional differences we have in place in the country, so we can have a more effective planning process in place. And the third aspect, which I believe is important, is resource allocation. They have 17 million inhabitants there, and the resource allocation is 12% of the GDP, and they have a 700 billion euros GDP. So it makes a huge difference because our system is underfunded, and we cannot continue saying that the shortages in our system and gaps are exclusively connected to improper resource allocation. But it's also that. But it's important to clarify that resource efficiency is a core aspect. And another aspect that I would like to highlight as a difference, and I believe is important to discuss that, is what they name as managed competition. And this seems to me something very interesting, but we need to take into account that when we talk about the private company that is providing services to the public healthcare system is different from the HMOs. These are truly different things because these are institutions that are non-profitable institutions, they are cooperative institutions, and they suffer a process of control and management from the state, which is extremely important and strong. Therefore, our system of private healthcare based on the insurance health plans are completely different. So I believe this is something important to stand out because sometimes we try to compare the cooperative model with this possibility in Brazil, and I believe in the way our system, the private system of healthcare insurance plans is organized with a very perspective towards the financial aspect and not towards the healthcare aspect. It's not possible to make this comparison. So I just would like to stand out two topics and finally say the challenges, demographic and populational technological challenges that they are facing, we are also facing in different sizes, in different age groups. In the 70s decade, and they are in the 80s, almost achieving 100 years, but the issue is at stake for us. And if we are not able to face all that in a structured, planned way, thinking about this organized future, we will have difficulties, and then we can inspire ourselves in the low-tech and high-touch model. So thank you, and I can now entertain the questions, interact in the discussion with you.
Thank you, Santini. Thank you, Marta. There were some questions sent to us, but Santini has emphasized that the system of competition is among cooperative entities that are not for profit. Services, providers, nobody operates for profit. Yes, we can hear you. Go ahead. But we have to be brief, because we still have got 2 or 3 more questions here. This is a model based on entrepreneurship. Providers and plans have to do something which is helpful to the citizens. Otherwise, organizations simply go bankrupt. It has happened already. The model is a cooperative model, but also competitive model. We've seen, for example, during the COVID pandemic, that the healthcare plan and the service providers got together in their best efforts. Healthcare plans or HMOs just stopped with a number of bureaucracy and actions to provide more hours and to provide better care to patients. I think it's a competitive model per se, but working more for the cooperation among the key stakeholders. So we're saying yes. They are not for profit. They do not share results to corporate members. However, in the rate of benefits or incentives that they offer, there is the possibility of delinquency, because if they cannot create their own market, they can become delinquent. Okay, or solvent. You said that all citizens need to have a healthcare plan. But I understand that even despite the inequalities that you have in Brazil, some have a purchasing power which is different from others. How does the government deal with that requirement for those that have a lower purchasing power than the others? Is there some kind of subsidy by the government?
Sim. Todos os adultos, os cidadãos adultos,
all adult citizens over the age of 50 have a mandatory healthcare plan. Children do not have to pay any premium. In addition to premium paid by citizens, there is also premium paid by companies as a co-pay, paid by general taxes. Everything together. And then we spend per capita about 6,000 euros every year. When you are born, you cost very little to the system. And in the past 3 years, of a few years of your life, you cost almost 60 or 70% of the entire cost of your health. So the government provides some equity. Yeah, so that's part of the new policies, and we've been working on reducing inequalities. Now, questions from the audience. There is one question by Gessimara Souza, and she asks you, when someone travels, the healthcare plan, even throughout Europe, is it covered throughout Europe, or it's covered only within the Netherlands? We have contracts with other countries concerning coverage. Let's say if something happens with a Dutch citizen in Spain, so we can provide care, and we do the same to a Dutch person here in the Netherlands. Tiago Ungier asked questions concerning continuing education. So healthcare professionals and physicians, is it managed by them, by the companies or cooperatives where they operate? Or is there any other way of professional update? These are all exceptions, really. We have permanent education. There are new profiles of physicians and nurses to deal with that in the future. So we have this support of education to really help people at home, to help home care, etc. Now I'd like to open to Martha and Santini to make questions or ask comments. We still have got 4 to 5 minutes, so that we can really take the best of your experience. I have one thing to ask Michiel, something that we discussed before, and I think everyone should be part of that. When we adapt the model, there are a number of differences in our two different cultures because of regulation. So we saw in this discussion a number of different, even regulatory differences of health system or health nature, but there are also cultural differences that we have to understand and work with them so that the application in Brazil can be effective. And it applies to any country, actually. But Michiel lived in the Netherlands and here. So my question to you is, of everything you've seen here in Brazil, public structure, the way you organize private services, what would it be a better adaptation that we have to do it here? Thank you. Very good question, Marta. Brazil has both sides of it, private and public, which are seen as two independent things, but in fact, what we try to do in the Netherlands is where we can add value in working with the healthcare system, which is a point of adaptation, culture. Health is a complex thing. It's not something linear that you can directly implement. It is something that involves a number of stakeholders. People want to get to know, understand, as professionals. Only in this environment is that you create shared understanding, you create trust and confidence, and you want to do things together. In Brazil, a number of the concepts are just part of the SUS system in Brazil as well, the universal healthcare system in Brazil. The primary care physician. There is a focus on health promotion, health prevention. Brazil should really consider public-private partnerships and really understand where something together can be created. Synergy, exactly. Synergy is the word. What about you, Santini? Your closing remarks? We cannot hear you. Your microphone is off. Very interesting thing, but unfortunately, it's a pity we don't have any more time, but it's very stimulating. I think we are all very much active to discuss that. But let me go back to the private model, because this is a huge challenge to all of us in Brazil. And the differences that I noticed by reading the material that I received is what they call private is, in fact, a not-for-profit, a philanthropic model, because the organizations are not-for-profit. And the participation of citizens in terms of amount of resources spent is much lower than the average ticket that a Brazilian would pay for healthcare plans here. Therefore, when we are talking about cooperation, private-public cooperation, we really have to understand what we are talking about. I think public-private cooperation is really important, but it's also important to define the meaning of each thing. It's not the same thing that is being presented in the Netherlands as we observe here in our private system. So we should understand what we are talking about. But the model, wow, the model is really interesting. Santini is absolutely right. there are different ways of having public-private partnership in Brazil. Not-for-profit organizations are ultimately responsible for much of the services provided here. So Santa Casa and other hospitals in Brazil, which is a model to some extent similar to what the Netherlands has in terms of service provision. But that's the other way around, because we are breaking, we are really just having our systems go bankrupt because of funding. So we are extracting value of the not-for-profit, but without allocating appropriate resources. When you talk about 12, 13% of GDP, we are reaching 9%, and the public healthcare system amounts to only 4%, showing that the country has not set any priorities for healthcare. Maybe some for education, but considering primary collective assets, health is undervalued. And all of us, the Brazilian society, we should work for better allocation of resources to health. Well, thank you very much for our three speakers. I have learned a lot in our presentation. And if I may quote Mario Quintana, those who are self-taught are the only ones responsible for our own ignorance. So we've learned that this is also very important to all of us. Thank you all very much. With that, I close this panel. It's been a pleasure to be here with you. Thank you very much. Have a good afternoon.